Well, we're missing some people, but I'm going to go on and start because it is 12 o'clock. It is cloudy enough today. We probably won't have the sirens go off, but just in case you don't know already, Arkadelphia does have a test of their uh, siren system for tornadoes and such that goes off at noon on Wednesdays when the weather's nice. So sometimes we'll have to wait for a minute or two before I go ahead and start class. So if you hear that, don't be alarmed. It's just the sirens going off for tests. We had a nasty tornado. No, there it is. There was a really bad tornado that came through here many, many years ago. So ever since then, they test it every week on Wednesdays, as long as the weather's decent. They don't do it when it's rainy or super cloudy or anything. So I was a little surprised they were doing it today, but it's not terribly loud, so it should be all right. I think. Oh, well, we'll see. This is a good noise canceling microphone, so hopefully that should do the trick enough. Today, we're going to talk about the treatment of psychological disorders. Of course, this is my area because I'm a therapist, but I'm going to just hit the high spots on this. I'll go into a little more detail. Of course, it's not a class about how to do therapy, but I do want you guys to just know some basic information about what kind of treatments you would use for different psychological disorders as we go through them. But psychotherapy is psychological therapy. That's all psychotherapy really means, but it's the use of psychological techniques and the client therapist relationship, which is really, really important to produce emotional change, cognitive change, and behavioral change. What we're looking for is change. Because if you come to therapy because you are, unhappy in some way, if you are having problems, what you're looking to do is help that person change and improve. So a lot of what we do as therapists is teach, which it means that, therapy is just a one-on-one version. It's almost like life tutoring in a way, because you're helping someone work through their problems and find solutions and coping skills for them. Now, psychotherapy, has a lot of different ways in which it can be done. Most therapists describe themselves as eclectic, meaning that they use a lot of different techniques from a lot of different methodologies. Just like a doctor doesn't use the same medication for everyone who comes into their office, therapists don't typically use the same methods for every single person. Now, that does not mean we're not going to have favorite things that we go to again and again, because we do. But it's not necessarily going to be, just one kind of therapy, because it is not one size fits all. Absolutely not. So as far as the different ways in which we do treatment, there are biological treatments that are done for some psychological disorders. Electroconvulsive therapy, or shock treatment, as it is very often called, is just that. It involves causing seizures in the brain of a person by passing electricity through it. They literally lay you down, they stick electrodes on your head and proceed to shock the bejesus out of you. Yeah, I know, sounds weird. Here's the deal with ECT. It used to be used in ways that were really questionable, but it was discovered that unrelenting depression, that nothing else helped, that they tried every kind of medication, every combination of medication, every type of therapy, and still had just unrelenting severe depression. And electroconvulsive therapy can actually shock some people out of it in some ways. Now, it is not just one session. It's usually 6 to 12 sessions over a few weeks. There are side effects to it. Memory loss being the most common. It's very, very common for people to not know what was happening, have no memory of a time frame before and maybe after the treatments. So that's kind of significant. And there can be some long-term effects with that memory loss, but for an awful lot of people who have really, really severe depression, it is worth it to them. I actually used to work with someone, not in mental health care, this was long before that, who had gone through ECT treatment for depression, and it really made a huge difference in that person. They had been, yeah, I kid you not, walking embodiment of Eeyore from Winnie the Pooh, just everything sucks, why even bother? It was so hard to be around them. And after the ECT, it was weird, because the first time I ever saw this person like spontaneously bust out a grin and laugh, it was like, what? You don't do that. It was so almost disconcerting, because that was just not something this person had ever done. And I've worked with that person for a long time. So yeah, it can be really, really helpful, but it is certainly not one of the first things that you try, because it's a big deal to go and get your brain shock treatment. So there's that. Psychosurgery, far less common. It used to be relatively common for there to be surgical destruction of the frontal lobe. It was called a frontal lobotomy, and it was actually done in mental hospitals early and mid 20th century, where people would basically get their frontal lobe kind of frappéed, and it would cause people to be very docile. If you had people who had a mental disorder that caused them to be very agitated or even potentially violent, this procedure would be done to make them more docile. We have medication now that achieves the same thing without doing literal brain damage to these people. So we don't do those anymore. There are not very many places in the world where that is still done. There is research being done to find out about other types of surgery that could be done to influence behavior. There's one promising thing called an anterior, what is it? Anterior, let me look. Anterior cingulate gyrus cingulotomy. Very small region of the brain, a couple of cubic centimeters basically, where the lesion, i.e. destroy lesion, is just a fancy way of saying destroy, this small amount of brain tissue, and people have really severe obsessive compulsive disorder, and it makes it just disappear. But it is brain surgery. They have to drill into your head and poke down into your brain. It's not right there on the surface or anything. They have to poke through your brain, which causes other brain tissue damage. So it's not a common treatment, but for people who have really, really severe OCD, that is a promising treatment potentially for those individuals, but it is certainly not the first line of defense for any of the psychological disorders. Psychopharmacology is one of the first things for a lot of people. Unfortunately, it is the only thing that is done. Psychopharmacology is simply using medication to deal with psychological disorders, use of medication to treat, psychological disturbances. Antidepressants, antipsychotics, or anxiolytics, and mood stabilizers are the four main classes. Antidepressants, of course, are drugs that are used to reduce or eliminate depressive symptomology. In 2017, the US, as I have written here, 17% of women, 9% of men on antidepressant medication in the United States. That's a lot of people. That is a ridiculously huge number of customers these pharmaceutical companies have. Antidepressants can be very, very helpful for a significant number of people. However, antidepressants only work for about 60% of the people who take them, which is a really garbage success rate, I gotta say. I mean, 60% is not a good grade, is it? So when you're talking about antidepressant medication, there are so many people that are on these medications and they don't get much, or if any, improvement on them. The most common class of medications are, yes. Okay, can you unmute yourself? What's your question?
Hi,
Hello.
this is John.
Hi.
I just had a question. You said that the success rate was 60%. Would that be like across the spectrum of antidepressants, or would like a certain antidepressant for somebody else?
That's pretty much across the spectrum, but it's, again, your mileage may vary. There are people for whom they work really well, and there are people for whom they do literally nothing and just give them side effects.
All right, thank you.
Yeah. One of the things with antidepressants in particular, the most common type of antidepressants are SSRIs, or selective serotonin reuptake inhibitors. And what they do is just increase the amount of the neurotransmitter serotonin that's circulating in your brain. And it is a mood regulating neurotransmitter. Dopamine is also a mood regulating neurotransmitter. Norepinephrine is also mood regulating. There's lots of different neurotransmitters that affect our mood. And the primary class of meds that we give people with depression are the SSRIs that only work on serotonin. So there are definite limitations. The advantages to the SSRIs is their side effects are generally relatively mild-ish. One of the most common side effects for the SSRIs is for them to just kill your sex drive, which if you're already, single and you're not in a relationship, it's not that big of a problem for you. But for some people, it can be a massive problem for them in a relationship, because if you have depression and, you already were feeling, bad about things in general, and then suddenly you're taking this medication that may help your depression, but you don't want to have sex anymore with your partner is going to feel rejected. So that can cause a whole lot of it just goes on with those kinds of things. Now, There are other antidepressants there are SNRIs like Effexor that also affect your norepinephrine levels. There are some other drugs, but here's the thing about the efficacy rate, the 60%, of people that find improvement. Why do people get depressed? People get depressed
It can be,
because, yeah.
oh,
Oh,
sorry,
yeah, go
I
ahead.
thought you were asking a question too.
Yeah.
That's my apology.
No, yeah, go ahead.
It can be due to situational depressions, or it can also be like chemical,
Yeah, yeah,
And if you
absolutely.
take like a antidepressant sometimes, it can actually cause like really like elevated mood for someone who's like on the spectrum of a mood disorder that's leaning towards like cyclothymia or something like that. So
Yeah. Wow. Okay. You know a lot of stuff already. Okay. This class will probably be pretty good, easy for you.
I like this
Uh,
stuff.
um, so exactly. People get depressed because their life is sucking for a time because they're going through a bunch of crap because their life may be at that time a freaking dumpster fire and taking pills doesn't put the fire out. There are reasons that people can have depression when everything's going swimmingly. Those people are usually going to be the ones that'll be more have more benefit from medication. If you are depressed and there's not a precipitating event for that depression, then it's more likely to be a biological cause for that depression. Whereas there's a lot of situational causes for depression, and all the pills in the world aren't going to fix the fact that you're grieving a loss in your life and you need to deal with that grief process. And that is why a lot of people, need to be in therapy and they don't. They go to their doctor and they get a pill to throw at their problems. We're really bad in this country about wanting to just throw pills at problems instead of doing the work. And it's work. Going to therapy is work. It is hard to take those hard looks at yourself and deal with your flaws and your problems and your issues. And I actually assign homework to my clients at times, so it is literal work. So that's part of the reason that antidepressants don't have a better success rate. So do keep that in mind. I'm not saying that antidepressants aren't good medications. They're very, very helpful for a lot of people, but there's also limitations for what they can do. You can't take a pill and have it fix the fact that your marriage is falling apart, that kind of stuff. So antipsychotic medication is medication that reduces or eliminates psychotic symptoms like hallucinations, some delusional thinking. These antipsychotic medications, this is one of my pet peeves, and I get up on a little rant about this, but forgive me. There are some antipsychotic medications that are given to people who have, say, like schizophrenia or really severe bipolar disorder or really severe depression. You can have depression that's so severe that it causes psychosis, that you are literally out of touch with reality in some significant ways. And in those cases, antipsychotic medication can be very helpful. I see ads in magazines and on TV for antipsychotic medications. If your antidepressant isn't working, try Abilify, try this thing, try that thing. And these are medications that are incredibly expensive, for one. And the side effects of antipsychotics are gnarly as hell, potentially. These are medications that can cause you to have type 2 diabetes pretty commonly. These are medications that can cause excessive weight gain very quickly. So these are things that can mess your health up long term. Now, for someone who has schizophrenia and they are so fraught with hallucinations and delusional thinking that they are unable to function in society, those side effects are worth it for a lot of people. Again, 1% of people have schizophrenia. It's a lot of people. If these medications allow those people to be, functioning members of society, it enables them to live independently, enables them to be able to support themselves, then yeah, I mean, those side effects still suck, but it's a worthwhile trade-off. For someone who has depression that's not even that severe, and they go to their doctor and go, "Hey doc, I look at this ad I saw in Good Housekeeping," and the doctor writes them a prescription for something that costs $1,000 a month and then gives them type 2 diabetes. because they never, sought therapy. Yeah, that kind of just honks me off because there are so many ads. And again, they're really aimed at women a lot of the time. I literally saw one that just pissed me off to no end because it showed a woman sitting on a bed with a pile of laundry trying to fold and going, sometimes I just don't feel like I can get through my day. Who likes to fold laundry? What the actual, yeah. So there are some things like that that I have seen that just really kind of make me crazy on that, because it's just so ridiculous to have somebody asking for a drug that is fraught with potential side effects that are severe and cost. These companies, these pharmaceutical companies may not have your best interest at heart. Yes, John.
Oh, I didn't mean to raise my hand. I
Oh, okay.
apologize. I didn't.
Okay, that's
Yeah.
fine. Okay, so these medications, again, I am not crapping on these medications. They can be absolute lifesavers for a lot of people, but just do be aware that a lot of these pharmaceutical companies, and I'm not painting them all with a broad brush, they're all evil, big pharma. Yeah, big pharma. Yeah, a lot of it is just profit driven. They're just trying to keep customers instead of helping cure illnesses and sicknesses. But do just keep in mind, be an informed consumer on these things. That's the thing. And you might, especially if you're considering taking antipsychotic medication, you probably shouldn't be getting that from your general practitioner doctor. You should be going to a psychiatrist. You should be seeing someone who really knows about this kind of medication and knows exactly what kind of dosage would be appropriate and those kinds of things before you go taking these meds. So there's that. Anxiolytic medications are drugs that are used to reduce or eliminate anxiety. The primary class, and about 9% of people are on these medications at any given time. These are drugs, the primary class of those are benzodiazepines. These are Klonopin, Xanax, Valium. These are drugs that work really, really well, almost too well. And these are drugs that can be addictive. They can definitely be habit forming. They have a real good safety record for the most part, used on their own, used as directed by the physician that prescribes them. However, just a couple of caveats with these drugs. They work really, really well at reducing or eliminating anxiety. They really do work well. They also can get you high. They also are very dangerous if you mix them with alcohol or other central nervous system depressants, especially alcohol. If you mix benzos and alcohol, it can straight up kill you pretty easily. You don't have to have big dosages of either one for it to be lethal. So it is very, very important if you are taking these kinds of medications, do not drink any alcohol at all. And now, that being said, y'all may know somebody who can take 2 milligrams of Xanax. It comes in 20.25, 0.5, 1 milligram, and 2 milligram. You may know somebody that can take 2 milligrams of Xanax and toss it back with with a water bottle full of, Jose Cuervo and party on. But there's also people that have died from taking, a milligram of Xanax, which was prescribed to them, and having a glass of wine with dinner. So just be aware of that. When you get that medication, there's a sheet of information that they give you with that. It tells you, contraindications and things that you should or should not do. And one of them is do not use alcohol with benzos. Again, the medications work really, really well. They do have potential for addiction issues. They do have potential for abuse. They have potential for, interfering interactions with the alcohol that can be deadly. So that is something to know. Now, if you leave the alcohol alone, it's actually pretty hard to overdose on benzos on their own. So again, they're quite safe, but they do have those caveats to go along with them. They work very, very well for a lot of people. It enables them to be able to deal with all kinds of stuff and have their anxiety controlled enough. One of the things that I have had experience with as far as, how these medications work, unfortunately, there are a lot of people who just don't want to feel any discomfort at all. And if you are on medication for anxiety, you need to be able to tolerate a certain amount of uncomfortableness. and not just expect a pill to make everything feel okay. And that's one of the problems that you can get into with some of these medications because, well, if one makes it tolerable, then two will make me feel good, right? Well, yeah, for a while. And then you're going to take three, and then it's going to be four. And then pretty soon you're going to have a full blown substance abuse problem. So, again, for people who have substance abuse histories or have first degree relatives with substance abuse histories, I would tread very lightly on these medications because, again, they do have potential for abuse. They work really well, but they do have potential for abuse. Is just, and, again, stay away from the booze with it. The other kinds of medications that were previously available that are still available in some limitations, the barbiturates. These were pretty popular in the mid 20th century. It's too easy to overdose on them. I would not recommend people taking those, generally speaking, because it's just very easy to overdose and die. Marilyn Monroe committed suicide on barbiturates. Whether it was on purpose or not, we don't know, but she overdosed on them and it killed her. So there's a lot of those kinds of older drugs that were basically replaced by the benzodiazepines because they're much safer. All right, and then we have mood stabilizers, which are the drugs that are used to reduce manic episodes in people. So that is something that's used for bipolar disorder. Yes, John. Did you raise your hand?
I'm not asking any question. I don't know why it's
Oh,
saying that I'm
okay.
asking.
Okay, no worries. Okay. For mood stabilizers, these are like lithium is the primary mood stabilizer that's tried nowadays. There are a couple other things. There's a couple of drugs that are used for epilepsy too, like Lamictal's another one that's used, although Lamictal's got a couple of really weird, rare, thankfully, side effects, but one of them is your skin bubbling up and peeling off in sheets, so I'd be a little reluctant to use that one. Lithium has been around for decades. Lithium started getting used in, I believe, the mid 20th century for bipolar disorder, and it does have, pretty good success rate. It's dirt cheap for one, but it also can build up toxicity in the liver, so you have to get blood tests regularly with it. It's got limitations for sure. There are a few other mood stabilizers that are out there that may not have as much problem, but again, expensive. Lithium is one of those like $5 prescriptions for most people, so it is dirt cheap because it's been around forever. So that's usually the first one that they're going to try for people, but you do have to get your blood tests regularly to make sure that your liver enzymes are normal. So there's that. And it doesn't work with everyone either. It's got about the same like 60-70% success rate. So there are plenty of people who it doesn't really do the trick for. So also with mood stabilizers, you have to keep that in consideration. So there may be, you may have to try a couple of different things. Manic episodes can last for weeks. In bipolar disorder. So, having a medication that you're on, you may, not need to be on it all the time. You may only need to be on it. Again, this is why you need to be seeing a psychiatrist instead of just your general practitioner doctor, because your general practitioner doctor is not going to understand the nuances of dosages and, taking your symptoms of, hypomanic or, ramping up into a manic episode, those kinds of things. So, if you have bipolar 1 disorder, especially, you need to be seeing, a therapist regularly too, because your therapist can help monitor that. Doesn't mean you need to see somebody every week if you're, stable on your meds and everything, but you still probably need to at least be checking in with somebody once a month or so, just to, monitor how you're doing on that. And then placebo effects. Of course, that's not a type of medication, but placebo effects are really, really important as far as psychopharmacology, because most of these drugs are affecting how we feel, and how you feel is subjective. And the subjectivity can also mean that we are influenced by other things besides the drug itself. So confounding variables get thrown in there. There are a lot of ways in which we can decide that a drug is going to help or not help our depression, our anxiety, what have you. So these placebo effects are something people just need to kind of be aware of. I have worked with people who were, who had major depressive disorder, and they would bounce from med to med to med, and it would work well for a few weeks, maybe a couple of months, and then they were right back where they started, and they'd be looking for something else because instead of doing the work to deal with their depression, they always wanted to just find a pill to fix it. And they would get better for a couple of months on whatever the newest thing was, and then they would go right back to their baseline depression. And I always would, kind of think it's like, okay, what is the root of this? Because clearly this is somebody who's probably not a primarily biological issue. Something else is going on. So again, it's just something to be aware of as both a consumer of these medications potentially, or as a practitioner, for to just understand how this placebo effect, how what you say about a medication could actually affect how useful it would be for someone. So you've got all of those kinds of things. Now going into the types of therapy. Again, and I'm only hitting the high spots, y'all. There are so many different, there's many kinds of therapies. It's kind of ridiculous how many types of therapy that can be done out there. But psychodynamic psychotherapies, Freudian psychoanalysis, the original type of therapy, Sigmund Freud would have people lay down on the couch and, say a list of things like, if I say tree, what's the first thing that pops into your head? Well, a normal answer would be leaf or branch. An abnormal answer would be noose. So things like that. Dream interpretation is something that's very, very heavily used in Freudian psychoanalysis, where you go through and record what your dreams were, and, talk about your dreams. And by doing this dream interpretation, you can delve into someone's unconscious mind. And a lot of dream interpretation is about your sex life because it's Freud. Yeah. Psychoanalysis can be useful for people. It can give them insight into why they think the way they do and behave the way they do. But my biggest beef with is it's super expensive and time consuming. We're talking typically 2 to 3 times a week for several years. And at the end of it, well, okay, you may have a lot of insight as to why you're a mess, but it doesn't give you the tools you need to fix it. There's not much in the way of coping skills that are given to people in psychoanalysis. It's more about exploring yourself, which is fine. But I don't know about y'all, but I don't have $750 a week laying around for me to spend on $250 a session therapy 3 times a week. And most people don't. So, and it's mostly done by psychiatrists and psychologists that cost a lot of money to see. So, if you are an idle rich person who has the time to do that and the money to do that, then by all means, be my guest. But for most of us living in the real world, not so much with that. Now, psychodynamic psychotherapy uses some of the same kind of background techniques, but is a much shorter version of it. It's usually more directive, and you do a lot of ego analysis, which, well, again, it's just not used all that commonly. But there are therapists out there who will delve into some of these types of things as part of, their overall eclectic way of treating things. But psychodynamic psychotherapy can be brief. It can be just a few months in duration. It is more directive. It does allow people to, learn more kind of coping skills for things. So it is more useful in that, but it's still dealing a lot with the unconscious mind. And, that's not my thing. Now, I know there are people that find that kind of stuff really fascinating and could find it really helpful, but it just depends on the individual you're working with. I primarily used client-centered and cognitive behavioral therapy in my practices because they work the best for people. They work the best and they work the quickest to get results. I mean, again, we're trying to help people establish change in their lives. So why wouldn't you use the thing that helps, the quickest and that's generally really well researched and shown to work? So within cognitive behavioral therapy, again, you're trying to change people's thought processes and their behavior. So some of the things that are used very commonly, systematic desensitization is successive approximation in reverse. If you remember from your operant conditioning part of Gen Psych. This is how you teach a rat to bar press, which is a very unnatural behavior. You do it through successive approximations. The closer they get to that behavior, you reward that behavior. Well, systematic desensitization is the opposite of that. You are getting someone into a very relaxed state through relaxation training exercises, through breathing exercises, and you are teaching them to not be afraid of something that is a phobic uh, issue for them, a phobic experience, a phobic item, a phobic situation for them. And it works really well, and it works quite quickly. You can go through a systematic desensitization program with a client in about 6 weeks if it's not a severe phobia. It can be definitely a problematic phobia, but not, a super severe thing that you're having to deal with day in and day out. And, people can get tremendous improvement in that or reduction in that phobic behavior, phobic response. Aversion therapy can be used for bad habits. Aversion therapy is punishment. It doesn't work as well. Punishment doesn't work as well as reinforcement. Aversion therapy would be like you've got someone with a bad habit, like biting their fingernails, and you have them paint their nails with a bittering polish. And whenever they put their fingers towards their mouth, they taste this disgusting, like the pith of an orange, just blech, pooey, terrible, terrible flavor. So therefore, they're not going to, stick their fingers in their mouth, and they can break that habit. There are things like that that can be useful. I've done that. I've had, I worked at a foster home facility for 6 years with, a lot of girls that were teenage, and they were biting their fingernails out of their anxiety, and they didn't want to do that anymore. So yeah, I mean, that in a situation like that, that could be useful, but that was hardly the only thing that we were working on with them. Aversion therapy in general for bigger stuff doesn't really work all that well. For small, for small nervous habits like that, it can work quite well, but for other things, it's not going to really help nearly as much. Operant conditioning in general, operant conditioning is just using, those principles of reinforcement and punishment to change behavior. Operant conditioning can be really, really helpful for dealing with children who have like ADHD issues, for dealing with people who have, OCD kind of things, to help change those behaviors. You can use operant conditioning techniques for that. Um, Reinforcement is a powerful force for us as human beings. So there's a lot of things that you can use that for. And it's fairly simple and easy to understand for most people to set up an operant conditioning kind of program to change a behavior, to change habits, to change lifestyle issues, like you're trying to get more exercise, or you're trying to, get a healthier diet, things like that. You can use some operant conditioning techniques for that. Especially for people who are, social skills. Within social skills training, you can use an operant conditioning program to reward someone for engaging in behaviors that they're afraid of. If you have a social anxiety disorder, and speaking to strangers scares the crap out of you. And one of the things that I've done many times with clients who've had these issues is do homework assignments where, okay, for this week, at least 3 times, I want you to go up a stranger and say hello, and make a note of how they respond. Because one of the biggest things with people with social anxiety is they're just overthinking and assuming that if they interact with someone, it's going to go badly. And for most of us, if somebody says hello to us, we're going to say hi, or I don't know you, but hey, or if you ask someone what time it is, they're going to tell you, and they're not going to be rude. They're not going to be snotty. They're not going to be mean about it. They're going to be like, oh, it's 11th, and there you go. So things like that. Social skills training is a way of helping people, learn how to deal with others. And it's not just for people who have social anxiety disorder. It's for people who just have issues with assertiveness. If you've got someone who is way too timid and people are mistreating them because they're easy to run over, you can do assertiveness training. You can do attribution retraining, where you get someone to stop having as hostile and attribution style, where they're just assuming that everybody is trying to screw them over. So things like that that can be used for social skills training. Um, you can do practice sessions, you can do some role playing exercises, things like that with people in therapy. So we got that. Beck's cognitive therapy, Aaron Beck's idea of especially treating depression, because depression is very much a disorder of thought. You get too much in your own head when you're depressed, and you stay there and you dwell on all of the bad stuff in your life and all the bad things that have happened to you. You're looking at the past with regret. People with anxiety look towards the future with fear. But with cognitive therapy, with Beck's cognitive therapy in particular, you're teaching people how to think differently about the things that have happened to them, and to stop as much of the ruminating and dwelling on things in the past, and thinking about things, getting into those cognitive loops where you're just thinking about something that sucks, that just makes you think about another thing that sucks, and makes you think about another thing that sucks. Oh, yes, doom scrolling. Yeah, there's something you young people talk about. When you get into a doom scrolling, I've done it. Oh my God, I do it. I've done it. I do it too often. I have to limit myself time wise on some of the stuff. I'm just like, oh crap. Okay, 10 minutes and we're done. It's another way of just controlling your thought processes. So it can be really helpful for people who have depression to try to work on not engaging in those kinds of doom scrolling inside of your own head. Rational emotive therapy was developed by Albert Ellis, who was this crotchety New Yorker who would tell people how full of they were in the middle of a session. And he was extremely successful. I don't think his demeanor would have flown too well here in the South, where we're all expected to be so damn nice. But one of the things that he talked about, which just I was like, oh my gosh, that is so, so, so true. He would talk about people shitting on themselves. Yeah, it's a play on words, sort of. But the shoulds, the tyranny of the shoulds. Life should be this way. I should be this way. I should have this. I shouldn't have that. We get so caught up in the idea of what life ought to be like that we don't live in the moment. We don't recognize the great stuff that we do have. We get so caught up in the wants and the needs and not knowing the difference between the two that we make ourselves miserable. So rational emotive therapy works on the rational side of the brain to try to bring some of that emotional reactivity that we all have sometimes under control, and to make you feel better about your life. It's a lot better for people to kind of be able to experience more in the here and now if they have either tendencies towards worrying about the future or ruminating and being sad about the past. It's much better to be able to kind of live in the moment, not too much, because you don't want to forget about the things that happened in your past, and you don't want to not plan for the future within reason, but not be completely derailed because something happens that changes your plans short term, especially. So there are a lot of ways in which rational emotive therapy can be really helpful. Then we have humanistic therapies that really focus on being real, being genuine. Client-centered therapy is one of the main humanistic therapies, and one of the three main facets of it are empathy, genuineness, and unconditional positive regard. Just empathy, being warm. And that's such an important part of having a good therapeutic relationship, what's called the therapeutic alliance with your client, for them to trust you, for them to trust that you have their best interest at heart, that you are going to work with them for their goals. That's really important, to not be judgmental, to not be a judgmental ass to somebody in therapy. That's a really important part of it. I use client-centered therapy techniques all the time at the beginning of a therapeutic relationship to make the person feel comfortable, to establish rapport, to help them feel comfortable because therapy is a soul bearing thing. I mean, you are opening up to a stranger and telling them some of your deepest, darkest stuff. So you need to feel comfortable with them. You need to feel like you can trust them. And client-centered therapy techniques can really go a long way in helping that. Now, that being said, client-centered therapy is not particularly useful for really severe mental health issues. When you've got someone who is out of touch with reality in any significant way, client-centered therapy and going to do squat to help them. But for the vast majority of people who come through your door as a therapist, you're going to be dealing with anxiety and depression, depression and anxiety. You're going to be dealing with some phobias. You're going to be dealing with some ADHD. You're going to be dealing with, some pretty run of the mill stuff. So client-centered therapy can be really, really helpful in all of that. Now, family therapy and group therapy are when you're dealing with more than one individual at a time. A family therapy session, of course, is going to be dealing with a family unit. You're generally going to be working on conflict resolution. You're going to be working on communication skills. You're going to be working on ways in which you can work on roles in that family. And I applaud anybody that does family therapy. I have not done a whole lot because, oh my God, it's exhausting. I could not do it all day long. I think my maximum would be 2 family sessions because you're having to pay attention to everyone and keep up with all of this chaos that's going on. And oftentimes it gets heated, people get upset, people get angry. So it's very, very hard to be a family therapist, in my opinion. Just to have it can just break off into a lot of people being emotionally kind of volatile at the same time. Of course, I was dealing with some pretty messed up family dynamics generally, for the 6 years that I was doing the foster care work. But yeah, group therapy is when you've got a group of people who are experiencing the same kind of problems. Like you have a support group for people who have, OCD. You have a support group or a group therapy session for people who are all dealing with grief issues. You've got a group therapy session for people who have, ADHD, or what have you, or panic disorder or bipolar disorder, whatever. But what's going on with the group therapy thing is that you have, generally speaking, a therapist, and it's going to be roughly 10 or less people. In fact, for you to get paid by a lot of insurance companies, you can't have more than 10 people in a session because it's just, you're not doing much as a therapist. If there's more people than that, you're basically teaching a class, and that's different. So you shouldn't get paid the same kind of thing for that. But in the group therapy that I've done, and I did quite a bit, a lot of it was like psychoeducational groups that I would be doing with people in day treatment who all had the same diagnoses. And I would be talking about how to manage the symptoms and how to deal with the problems that come up for commonly for people who have those issues. And the members of those groups could be support for each other, which is really wonderful. Now, there are certainly types of disorders that group therapy probably wouldn't be the best for, like sexual addiction issues. Yeah, get a bunch of people who are addicted to sex in the same room. Probably not the best idea. It's like having an AA meeting in an open bar. You just shouldn't do that. But for group therapy, for a lot of people, it can be a way for them to get a professional involved in their care, but not have to pay as much also, because group therapy oftentimes will be much, much less expensive than individual sessions. So that can also be, a useful part of a group therapy experience. But just having, a trained professional kind of facilitating the communication and adding, information in here and there could be really useful. I liked doing group therapy for a lot of my clients. It was really helpful for especially for the day treatment clients that I worked with in a couple of different places. So group therapy can be really useful too, but it is, again, finding the right group to fit in, and you need to feel comfortable, and there needs to be trust within that group, because you are not supposed to talk about your stuff outside of that group. So you are leaving yourself somewhat vulnerable to other people talking about your personal business when you are in a group for group therapy as well. So there's those kinds of issues. All right, I am done. You guys have a wonderful rest of your week. I will again see you on Monday in class, in person, in 313 in McBrien Hall. For Friday, you have your assignment in Canvas, so make sure that you get that done. And I will see you guys on Monday. Oh boy, I'm so looking forward to being on campus with all of you. So we'll see you then. Have a good weekend.